In this episode of the Nurse Practitioner Podcast, Ketel discusses suicide detection and treatment. Would you mind telling us about yourself and how you got involved in this type of work?
Yeah. Taylor, thanks for having me on the podcast. First of all, I have been an all-around nurse for about the past 25 or 30 years and really served at all levels. And so started as a technician in a nursing home, fell in love with patient care and worked in hospitals as an acute care nurse and then an acute care nurse practitioner and adult nurse practitioner. During that time as a nurse practitioner, I was fortunate enough to be able to work and develop Vanderbilt University Medical Center's had a hand in developing their surgical weight loss program and their clinic structure, and really fell in love with the whole systems management in healthcare and the impact that you could have, and slowly transitioned from doing direct patient care in the hospital to taking on leadership positions. I would say how I got to where I am exactly right now would be, our topic is suicidality and primary care. From my background, you can see that I'm neither a psychiatric nurse practitioner nor a primary care nurse practitioner, and would not claim to be an expert in those fields. What I am an expert in through the work that I've done is in systems design, implementation, evaluation, and evaluation. So, that's where I'm at with my big picture life career. Where I am working right now with Vanderbilt is in the realm of the serving underserved and working with eliminating health disparities and inequities within the city of Nashville, and then reaching out to the Middle Tennessee area. And so with that, we've developed a program in our clinics. We currently have 2 clinics within our system that serve underserved individuals and families, and we offer primary care integrated with behavioral health care and social service care. And so we've been doing that for about the past 10 years, and we have had a significant impact on the population. So that's our background in a brief sentence. I'm sure we'll get into more of our history and some of the details.
Great. And what caused you to focus on suicidality specifically?
So back in our history, so our clinic system that we started to primarily focus on primary care, doing preventative care, doing, the preventative maintenance for populations and your general primary care, what you would specifically think of as traditional primary care practice. We found that particularly working with the underserved, we were being asked to help with the treatment of both social service issues. So we quickly learned that we needed some social service help from licensed medical social workers. And then we also found that simply providing traditional primary care was not able to meet a lot of the behavioral health issues that folks were having in our community. So we looked into the literature and we found a great model called the collaborative care model out of the University of Washington. They're officially called the AIMS Center model. And we have been able to successfully use that model in a team-based care environment in order to expand our reach from just being able to provide traditional primary care medical issues into focusing more on low to moderate. And then as we get into more of the conversation of the work that we're doing into moderate to even severe psychiatric conditions such as suicidality and other major psychiatric conditions. It's not ideal, but we really found that we needed to do that because there was a growing decrease in the accessibility of psychiatric nurse practitioners, psychiatrists, psychologists within our community, that the needs of the population were just not being met. That necessity drove us to create a system within our primary care network and really think about how we treat our patients as entire medical, social, and psychiatric or mental health, pull all those together and be able to meet all of those aspects of the need. Because we found that with patients that we only focused on one or maybe 2 and not the whole package, that it would almost be like a 2-legged stool. We couldn't make changes in 2 of them in ignoring the other one. And so that's really what brought us to a point where we needed to focus on providing overall behavioral health care in the primary care setting, and then generally, and then specifically the work that we have done with suicidality.
Great. And how did you and your team get started?
So the first thing that we did, we noticed a problem. And so again, going back to that 10,000 foot view, we knew that we weren't adequately meeting the needs of the population through our own system. And so again, we went to that literature and we collaborated with the folks at the AIMS Center and we looked at best practices. And so one of the aspects of the AIMS Center model is an aggressive screening for patients for mental health disorders, and it focuses in on a treat to target so that you're using validated tools that are able to provide the provider and the patient's able to express in a somewhat objective way their overall mental health. So we had implemented the traditional and what is standard of care now and implemented depression screening and anxiety screening within our practice. But then we found that when we added depression and anxiety, we were getting a higher number of patients that were screening that they were needing help. And so based on that needs assessment, we implemented a universal screening for depression, anxiety, substance use disorder, trauma, so psychological trauma like PTSD, and suicidality into our screening. And we didn't make the algorithm to be, if it's depression, we'll ask the depression screener. And if they seem depressed, then we'll ask about suicidality. We'd had a specific question where we were very upfront with the patient that we were going to be asking these questions at each visit, no matter if it was a behavioral health visit, a social service visit, or a traditional psychiatric visit or primary care visit. So with that, our goal was 100%. We can get into this a little bit more as we drill into the exact details of our experience with that. The first impression that we had was, number one, we knew that we were going to get depression and anxiety in levels. When you start asking, they'll start telling. What we were very surprised at the rate of suicidality within our primary care population when we started to ask. Specifically, those with that screening, the first thing, I'll be 100% honest, we had team meetings once a week, and my social workers and my team were coming to me and saying, why did you ever have us begin screening every single patient for suicidality? Because they're all saying yes, and we're having to deal with these patients that have suicidal ideations. And so that's, as a provider just working in acute care setting and hospital, that's the last thing that you want to hear when you see somebody. I can't speak for all providers, but me in particular, when you think that the direction of the patient is going is that they're having some sort of psychological crisis, you feel like you're not in your comfort zone. And so what we learned is that, we needed to make this in our primary care practice. When we ask these patients, we needed to bring a sense of comfort to the provider that they are confident and know what they're doing. And we went back to AIMS, our consultant for the collaborative care model, and we defined a second level of screening after that universal screening. So once someone is, we ask and say, hey, are you experiencing any suicidal ideations in a way that the patient can understand and answer? And when they say yes, to understand that it's no different than any other condition that they come in, and being able to ask that question, whether you didn't ask that question or not, they are that way when they're there. And so we found that we were able to use two sets of tools, or actually three sets of tools, the Columbia Suicide Severity Scale and the ASK questionnaire. For once someone says that they have suicidal ideations, we can actually break that down into a continuum of identifying whether they have passive suicidality, which means that they aren't actively looking for means to kill themselves, but they are having thoughts in their head that, that things like the world may be a better off place without me, or if I woke up tomorrow, wouldn't be any difference in the world. And those are all thoughts that are not good to have. They don't need to go see a crisis management person right away, but knowing that in a primary care setting sets us up to be successful providing them care on a wraparound basis for everything that they're doing. And so if that's the way that they feel, it's very difficult to have that patient think about other modalities in their care. So that those screeners then on the other side of that continuum, a true crisis emergency would be active suicidality. They have thought of means, they have thought that they are ready to activate this desire within them to act on their suicidal ideations. And that's a very dangerous place. So within that range of patients, obviously, there's different modalities of care between your patients that have a mild ideation, and you can deal with them, on a one-to-one level in the primary care office, to all the way up to a true emergency where you need to activate EMS and you need to activate a much higher level of care. And so that was that first couple of weeks that we started screening for suicidality. It was difficult in our world of care in our provider teams to be able to differentiate between those two. And so, again, if there's one thing that we always do is go back to that literature, and we found a tool called the SAFE-D tool. What it does is it takes that severity scale, whether it's the Columbia Suicide Severity Index or whatever suicide, whoever lets you know where they are in this continuum. It gives you basically treatment options and treatment plan that you can do with that patient. Basically, I'm very comfortable with having providers have algorithms and things that they can follow, almost like a checklist for when things happen. And that really helped our providers in the interim. Now our providers go in and it's just second nature for them to move through this process and help their patients. And they're not really getting over excited if someone is passive. They know what the processes are and they're able to treat that patient. So that's a long answer to that question. We do have some evidence, if anyone's interested in learning more about that process, that I've written an article in the Nurse Practitioner that came out, I believe it was late last year or mid last year. So if you want to look into that, that goes into our entire process and some of the outcome data.
Thank you for sharing those tools with us. Would you be able to delve into a little bit more on how you started and if you had any expectations as to what you were getting into?
Yeah, that's a great question. I will say that we knew our expectations were, we thought that we were going to get 10% of what actually was in our population. So when we got started, going back to our, using the collaborative care model, and one of the parts of the collaborative care model in primary care and integrating behavioral health is gathering data and making sure that you have the data that you need to be able to treat the patient. And that was primarily based on the PHQ-9 and the GAD-7. Once we started asking about those two aspects of someone's mental health, it really broke open the other areas in which we needed to look at. For instance, for this specific topic, suicidality. Also, another one that we found is a large amount of PTSD within our population, and then also a large amount of substance use disorder. In our research that we're doing, we haven't looked at correlations and things like that. We were motivated to provide better care and services to our patients that we serve. So when you ask how we got started, it was an iterative process of really starting with primary care, incorporating social service care, looking at things like the social determinants of health of a patient, and then really were intentional about when we added our behavioral health integration and going back to using a well-established model to do this. And then, like you said, level setting our expectations. But I will say that suicidality screening in our population shook us off balance for a little while with the amount. So we looked at 2 years worth of patient data, and we had a little over 1,700 patients. Of those 1,700 patients that were all universally screened for suicidality, 8% of those patients had suicidality at the time of their visit. And so to me, that's significant. That's almost 1 in 10 patients that are coming into the office at any given day. And if you think that you're possibly seeing 10 to 20 to 30 patients a day, that 8% can really add up. Also shocking news is these weren't just patients that we had identified psychiatric conditions, or they were being seen primarily for a mental health, anxiety, mood, or pain, any of your kind of psychological psychiatric visit types. These were patients coming in for physicals, and they were coming in for their sick visits. They're coming in for their well women physicals. They were coming in for just all kinds. And it was really broken down. It was, of the 8% of the patients that were screened, out of that 1,700, 2/3 of them were there for strictly primary care conditions, and the other 1/3 were there for more traditional psychiatric conditions. And so it really exposed to us how important this universal screening was and what an important role primary care could have in helping mitigate a lot of the problems that we're seeing in the lack of access to mental health care within the Nashville area for us where we are, but it is really a national issue of, number one, a national issue of that suicide rates in the U.S. have been climbing for 10 years. And then mental health morbidities have been increasing in the last 10 years. And this is even before COVID. And then if you combine that with that we're just not able to produce enough psychiatric providers, I really think that the role of primary care to help be a solution to this problem, particularly for patients that are having mild to moderate mental health conditions. There's just a huge potential for them to do that through integrative collaborative care with integrating behavioral health and physical health, but also at minimum, just being able to identify your patients that are at risk and connecting them with outside resources.
And how did implementation screening go once you began, and how are things going now?
So like I said, the screening was a shock to us. On a daily basis, we were having that 10%, 8 to 10% amount of patients. I mean, it was at least 1-2 a day that were patients that were reporting us that they had suicidal thoughts. The benefit of us having that established pattern of being able to identify where that patient was on the continuum was pivotal for us. And so we were able to create a system, a post, really out of necessity. At the end of the day, we would have loved to be able to just refer these patients that were having mental health, subacute or sub-crisis and even crisis level. There was barely enough resources within the community to handle the people that were acutely suicidal. When we started screening, we really found that we developed comfort through our standardized processes and our providers' comfort level that we were able to successfully develop a system of care within our practice that we would be able to provide that patient with what they needed without having to refer or immediately having to refer. So for instance, for people who were experiencing passive suicidality, mild passive suicidality based on these scales, we were able to create a plan for them. We were able to assess, their support networks. We were able to assess whether they had means for suicidality. And both of these are two aspects of suicidality that we look for. So there's positive factors in these patients that we are looking for to be a deterrent for someone, or a strength that they have that would deter them from progressing down the continuum towards suicidality. One would be a strong social network, one, pets, or strong religious beliefs about not killing oneself is a very strong protective factor. Then you have on the other side, you've got negative factors, or what we would call risk factors. And those risk factors might include having access to guns, having a low social support network, divorce, or losing a job or something like that. So you can take that on an individual level and, look at those risk factors and figure out where they fall on that continuum and make a treatment plan for them based on mitigating those risk factors and strengthening those and increasing those protective factors. We found that when we could categorize folks and help them at that level of treating in a mild to moderate situation, we were not needing to refer, people got better managing them on this lower level of care without having to escalate them to higher levels of care, which we normally would want to, but we couldn't because there was no access. And so that helps us in a couple of ways. Number one, we're not continuing to overburden the psychiatric providers that are just honestly trying to get out there and serve a demand for patients that just has skyrocketed over the last few years. So we have implemented this in 2 primary care clinics and have implemented this in our midwifery practices. And that's been a whole different kind of subset of patients that really the only thing that we've really had to adjust would be what screening tools that we use. And so, instead of using the PHQ-9, a lot of times we'll use the PHQ-9 and or the postpartum depression screeners that they have available to them. In our population, we really found that we had a large number of substance use disorder issues, in some of our other clinics, that doesn't seem to be an issue. So we're adjusting how much and how often we ask that, with the basis of always universal screening at each visit, because of what we've learned that depression, anxiety, and suicidality. So our future, we've got some ideas that we want to do in the future with this program. And so we've been, again, successful with implementing a suicidality detection and treatment and prevention program in our clinics, which are with our traditional brick and mortar clinics using telehealth and having people come in. Our next big phase is going to be, we're going to be working with a community partner that actually goes out with a large mobile bus and be able to apply these into more deeply medically underserved areas and also into our rural communities, which will be a new area for us to be able to, it's another opportunity for us to do a needs assessment and better understand a new population that we can use this in. From our data that we did a quality improvement data analysis over 2 years worth of data from 2018 through 2019, those 2 years worth of data. And again, we saw that through screening, we were able to, that we did have 8% of that population that was suicidal at the time of the visit. Of those patients, I think it was 167 or 169, of those 160, almost 170 patients, we only had to utilize the emergency management system 5 times. All the rest of those patients, we were able to, through a treatment plan and follow-up and working within our primary care integrated behavioral health scope, we were able to manage those patients. And with the patients that we were able to see, 75% of those patients had complete resolution of their suicidal ideations, and we're keeping track of them. And so the things that we do next are not let down on that tracking. So, we've worked with folks, we've built up their strengths, we've mitigated their risks, and now we're continuing to follow up with them so that we can monitor them, just like any other health condition that we might monitor in primary care.
To close off today's episode, what advice would you give a practice wanting to start or take their program to the next level? And would you have done things differently if you could go back?
Yeah, that's a great way to end this. And I'll start with things that I would do differently. Things I would do differently is not underestimate the amount of need in our communities for mental health services, particularly in light of COVID and the kind of societal stressors that we have. These issues aren't going to go away. And I think that putting our head in the sand as a profession and not really tackling hard the societal pain that we're experiencing right now on all levels is something that I will not personally do. And I really hope that the other thing that I would have done differently is preemptively better supported my staff and my clinicians as we were navigating these waters. I had an idea that there was going to be a large amount of mental health issues that we were going to need to tackle in a systematic way. We had been doing that, but suicidality really shook us for a loop. It's one thing to read articles about this. It's another thing to experience it in real life. And I would have taken more of a serious look at having had designed, or at least tried to design, processes before asking, and then had those processes in place for when we started getting positive responses. The next advice that I would give is we have too long in our healthcare profession moved down the path of separating mental health and physical health to be an aspect of where even our insurance companies take a different tact on. You have different insurance number for if you want to see a provider for mental health and if you want to see a provider for medical health. And I think that we've gone a long way down that road. And I think that programs like the collaborative care model, and I use that model a lot because it's the one that we decided to use, but there are many other great models of integrated care. And I think that if you're a primary care office or a primary care practice, I would strongly recommend that you start looking into those models and seriously consider working on some even small steps towards practice transformation, increase your team-based care, and then working with intentional ways to build up your ability to provide behavioral health care, simply because it's just knowing that patients are in need of it and that our colleagues in the behavioral health and psychiatry settings are doing their ultimate best and we just cannot produce enough of them to meet the demand. It's just at that point. I think the other advice that I would give is, again, to think of suicidality or behavioral health comorbidities as not creating a separate category, in a sense of looking at them as if, depression, I'm not comfortable with depression, so I'm not going to treat it, or I'm not going to do anxiety, or I'm not going to, I don't want to ask about the suicidality because it's uncomfortable for me. All of these conditions still fall into this continuum of mild to moderate, which is, in my mind, is very reasonable and safe to practice on a primary care level. If you're not working in an integrated care setting or haven't moved in that direction, the first thing I would do before universal screening would be to connect yourself with your state suicide prevention. There's a great website if you go to the CDC, or even just put in your state and suicide prevention network. Every one of these states has a great suicide protection. I would get integrated with that and get to know your representative really well in developing your colleagues in your other services within the community that can help. The analogy that I like to use is someone comes into your office and is in obvious distress from chest pain. You're not going to have any hesitancy to ask, are you having chest pain? And if they're having severe chest pain, you're not going to hesitate in calling 911 or admitting them into the hospital or getting them worked up for a heart attack. And that is a crisis situation. There's all kinds of things we do in primary care to prevent that. So we monitor blood pressure at each visit and make sure that that looks good. We monitor their blood glucose or their A1Cs if they're diabetic, or a yearly screening to make sure that we're covering those risk factors. We give them advice on living healthier lifestyles and building up their capacity for those positive factors. I just wouldn't create this separation in your mind between the mental health and the physical health in that regard. So I think that would be what I would want people to leave with. I think the last thing, and if people, I'm going to say this last because I want people to remember this, are that nurses and primary care are really the first line of defense for anything in healthcare. And I really think that is because primary care providers, nurse practitioners, physicians, anybody working in primary care, we're a trusted source of information. We're a trusted source of support. And I know for some of our patients that we see, sometimes we're that only source of support. And so I want people to leave here feeling empowered that they're doing a great job. They're getting a lot asked of them, but it's because I think that we can handle it.
Great. Thank you for joining us today, and thank you everyone for listening. You can find Vanderbilt Health and Vanderbilt Nursing on Facebook. You can also find the Nurse Practitioner Journal on Instagram, Twitter, and LinkedIn. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.